research that we've been doing up to over at KCH. Okay, just to kind of give you a brief overview of how MRI is used clinically. I mean, the obvious case is that there's some kind of diagnostic imaging that's required because the patient's got some kind of disease or got some symptoms. T2 imaging. So here's an example of someone with hydrocephalus. A prime example, we have clinical meetings. So a few weeks ago there was a kiddie who was going to open a chest of drawers and pulled the drawers a little bit too hard. There was a big TV on top of it and the TV landed on top of him. So this isn't this particular case, but this is an example. And so when that happens, often there's swelling, they get this water on the brain. You can see here ventricles which are normally much, much smaller, enlarge, and you're in danger of squashing some major artery and causing an ischemic event. So one treatment for this is a shunt, where effectively they stick a tube into the ventricles and they remove the fluid and they put it into your abdominal cavity. So you can see that we used imaging beforehand to prove that they had hydrocephalus. We imaged with the shunt in place to make sure the shunt was going into the ventricles properly. And then afterwards you do some imaging to prove that it's actually worked. So that's kind of just a basic workhorse of the type of imaging that we do. Moving on to some slightly more advanced techniques. There's something called moya-moya disease, where effectively some of your blood vessels haven't grown properly and you're reliant on your collateral circulation, so rather than your main arterial circulation. And so these collateral blood vessels aren't quite so strong and there's a chance that they can rupture. And so we can apply the gradient echo imaging, which is supposed to be sensitive to little bleeds, or we've got this more advanced technique called susceptibility-weighted imaging, where we become extra susceptible to blood products that have potentially kind of come out of the blood vessels and leaked into the tissue. And so you can see here, there's a couple of little black dots which are indicative of a patient actually having a rupturing one of their blood vessels. So another case, we can put images into movies. So in this case, we can do this thing called a CSF flow cine. Here we've got the patient's cerebellum. In certain cases, you get herniation and it squashes the aqueducts that allows your CSF to transmit down from your ventricles into your spine. And when that happens, you can get the hydrocephalus effect that we saw before. So through the cine, we can actually see better whether or not there's some kind of disruption in the flow. And then another one is just angiographic sequences, where we actually just look at standard blood vessels, and if someone's got an arterial venous malformation, like we've got in this case, so you can see it because you get a big bundle of these blood vessels all together. Okay, so this is kind of the basic stuff that I honestly don't get too involved with. It's the stuff that's happening sort of every half an hour on a day-by-day basis over across the road in any imaging department. So I get involved in this more physicsy imaging, which particularly has applications to neurosurgery. So I'm kind of going to start off with a couple of sort of popular culture examples of where people have discussed neurosurgery and neuroimaging. So in particular, there's a documentary on the BBC called The English Surgeon. It's about a neurosurgeon at St George's Hospital called Henry Marsh. So he devotes all of his annual leave and all of his holidays to going to the Ukraine, and he takes all of like the leftover rubbishy tools that we have here over to the Ukraine, where they have absolutely no neurosurgical kind of departments, and for 2 weeks he spends all of his time trying to help Ukrainians that desperately need neurosurgeons. So there was an interview with him where an interviewer was discussing about brain surgery. So this is what the question the interviewer asked. He said more or less, he thought it would be pretty easy to tell the difference between regular brain matter and a tumour. He sort of thinks that a tumour stands out, it's all yellow and bloody, and it would be really easy for a brain surgeon to identify it. But what this Henry Marsh's response was that actually, in some cases, particular types of tumours in particular, the tumour actually looks like the brain. So it makes it really difficult to differentiate it from normal brain tissue. And the way that they can do it, best of all, is by using the neurosurgical sucker. So effectively, when they're cutting out the tissue, they're sucking it out with the sucker. And they use that and they push into it, and they can feel that it has a different sort of, it's a different texture, more or less, or different pressure feeling to it with the sucker. So this is the best way in certain cases that they can actually identify where the brain tumour is compared to normal tissue. So you can see straight away there's a bit of a problem here, because it would be good if a brain surgeon can actually identify the tumour, because that's the bit they're trying to cut out. So my first example. So the second bit, hopefully you can hear this. This is a BBC4 documentary that was on several years ago, where they filmed a live brain surgery at Queen Square. So if anyone's particularly squeamish, because it is a live brain surgery, and I've had people complain when I've shown this before, maybe you want to turn away because you'll see the skull off and you'll see the brain kind of pulsating and stuff. So, and there's audio, but it's a bit quiet, so hopefully you can hear it. Oh, there's not audio at the moment.
Establish exactly where he is, Catherine's brain before he removes the vascular tumors.
So there's a little brown discoloration between this rather unusual loop of a vessel there.
And that's probably the cause of epilepsy.
Not aesthetic. So what we have to do now is to make sure that area that I want to remove is performing some element function for us. So we'll stimulate all around it,
right.
Make sure that it's not moving a leg or a hand or a face, make sure it's safe to remove. Now, Catherine, what you're going to get here now is every now and then you're going to hear a little buzz.
Right. The danger with operating on the brain is that it's easy to cause collateral damage. You could leave an arm or leg permanently paralyzed.
Okay, yeah. Do a little buzz every now and then, okay? Okay. Yeah. Anything at all? No. Same again. Same again. Oh, yes.
That's the one where I get
Andrew is stimulating Catherine's brain with an electrode to identify precisely the areas and control sensational motor skills.
Okay, fine. Let's go to 1.5. That's good. Same again, Catherine. Oh, yes. So what we've got here, this area here all moves the hand and arm. This area here is the foot. This area here is the leg. And then as I came up behind the lesion, we had a little bit here that was contractions in the face.
Yep.
And then there was directly behind the lesion, there was an area here that was obviously causing eye deviation. Interestingly, she reports that's exactly how her seizure starts.
Right.
So,
Now that he has identified the area he can safely remove, Andrew is ready to cut out the vascular tumor.
Okay, so that was supposed to highlight the idea that you've got these eloquent parts of the brain, and when a brain surgeon goes in, he needs to make sure he leaves those intact, otherwise the person may end up with more of a deficit that makes it worse than what their original condition was. So I kind of tried to highlight here two problems that we have that we try and solve through imaging. The first one is we need to identify the tumour from normal brain tissue, and the second one is we need to identify these eloquent brain regions from what I call the more dispensable parts of the brain that they can cut out, and effectively you don't end up with a deficit after the surgery. So I'll start off with the first point. Okay, so in our standard imaging routines, we've got kind of a number of tools for us to identify lesions. We've got this fluid attenuated image, FLAIR we call it. We've got a second one which is gadolinium enhanced imaging, where we actually inject a contrast agent, and the contrast agent actually gets taken up by the tumour. So I've got two cases here. They're both high-grade tumours, and you can see the flares both give you kind of a demarcation of where the tumour might be. But in the second case, the gadolinium contrast agent doesn't seem to show up very much. So the problem here is the flare isn't actually showing the tumour. It's showing edema. It's showing like the interstitial fluid that gets released around the pathology. So we can't really just use the flare. You can see here that the flare's kind of going all over the place. So we can't use that by itself to define exactly where the edge of the tumour is. In this case, the gadolinium would be a good image to use to define the edges of the tumour, but in certain cases it fails. So we need to bring some extra bits and pieces into our arsenal to try and identify where the tumour is. So this brings in perfusion imaging. So a lot of you, if you work in research, may have heard of perfusion imaging in the terms of arterial spin labelling. This is a slightly different flavour of perfusion imaging where, because we're actually doing the contrast injection, we're able to get the blood flow characteristics much, much quicker. So what we do in this is that we inject a contrast agent. It takes about 10 seconds for it to go through the venous system, the arterial system, and up to the brain. And then when it's in the brain, we get a series of images at about 1.5 seconds per image to get an entire volume of the brain. So every 1.5 seconds we get a volume. And if we had to look at the signal intensity, say, within this little region here, as a function of time, then what we find is that as this injected bolus, we call it, this little bubble of contrast agent, moves its way through and eventually gets to the brain, we see this drop-off of signal intensity. And as it passes through the brain and enters back into the venous system to get pumped back around to the heart, you see that the signal intensity goes back up again. So this little dip here has information about how much blood flow there is and how much blood volume there is in different parts of the brain. So in fact, if we look at that little white arrow there, that's the rate at which our signal intensity is dropping, and that's telling us how quickly blood's flowing into that particular region. So we can do this on a voxel by voxel basis, and we can look at every single little tiny voxel in the image, and we can work out a map of how much blood there is flowing to different regions. And the other thing we've got, if we look at the area under the curve, that tells us how much volume there is. That just tells us how many blood vessels there are in each particular voxel. And both of these things are increased when we've got a tumour. So effectively, this is a way that we can kind of demark the edges of the tumour or show us the volume of the tumour by creating these maps. Okay, so if we go back to this second case study again, where I said this standard gadolinium contrast enhanced image didn't work, if we look at the perfusion image, you can see that it does actually seem to give us a bit of a volume around where the tumour is. So what we do now is, if we had to draw a little circle around this volume to create a boundary, we can put this into an intraoperative microscope. So this is what the surgeons are actually looking at. And through certain registration techniques that I'll talk about later on, we're actually able to give this information to a surgeon, so when he's looking down and he sees something that looks like normal tissue, he can actually see where the edges of the tumour probably are. Okay, so that's kind of an idea of how we solved that first problem. So the second one, how to identify these eloquent brain regions. We've got a number of techniques for that too. Okay, so this is an example of what happens during surgery. We've got our image of a tumour before surgery, and then after surgery, they literally just go in and cut it out. It's fairly aggressive, and our goal here is to identify whether, beforehand obviously, whether there was any eloquent regions in there that the surgeon should have left behind. So everyone probably knows what a nerve cell looks like. So in particular, we need to identify both grey matter and white matter. We can't just look at one, because effectively if you chop out some grey matter but leave the white matter, the person's going to lose their function. Likewise, if you leave the functional grey matter there but you chop off the axonal connections, then they're also going to lose that function. So we need to think of ways of identifying both. So we've got ways through imaging. One is through functional MRI for grey matter, and diffusion MRI or tractography allows us to map out these white matter pathways. So I'll start off with diffusion MRI, diffusion imaging. What we do here is we take a series of images and we apply extra gradients along different directions. And what these gradients do is they sensitize the image to the motion of water. So effectively, by taking all of these images, where each one of these images has got an extra magnetic field gradient, we're able to map out whether there's a lot of water along that, a lot of movement of water along that particular direction. And then we can create these extra process maps where in every single voxel, so I've looked at this region here, we can create what we call these diffusion ellipsoids. And they represent the amount of water at each point, and the direction, sorry, the amount of flow of water, or diffusion of water along each direction. So if we look at this particular voxel here, we can say predominantly the water's flowing in this direction, but there's a small amount in this direction, but it's definitely greatest in this kind of vertical direction here. So we do this for every single voxel inside the brain. We kind of map out the properties of the way the water's flowing. Okay, so now we can use this to map out the white matter pathways. Because if we've got, it's a schematic of the corticospinal tract. So what we do is we say that we know we've got this nice kind of long white matter pathway going all the way down to the spine from our motor cortex at the top. So if we pick a region that we know is within this corticospinal tract. So I'm going to pick the internal capsule, which is a point here. And then we look within this region at what the direction of water is flowing. And we follow that direction along, we can actually map out this pathway. Because what we're doing is we're making the assumption that if you've got a whole bunch of axons that are all bundled together, then that means that water is going to more readily flow along those axons than against it. So we're kind of mapping out the way the water would be flowing, and at the same time that means we're mapping out the axons. So what we do is we create this pathway, we follow it along, and then we know that the pathway is supposed to stop up here in the motor cortex. Okay, so here's some clinical examples. What we've got here. We've got a patient here with a tumour called oligodendroglioma. So you can see the tumour fairly obviously right out here. And then we've run tractography from the internal capsule and we've picked out the bundle going to the motor cortex. So what we've got now is this question of the surgeon wants to cut out this tumour, but how posterior can they go here? So, you know, ideally they'd like to be really, really liberal and cut out as much as they can so they're sure the tumour's not going to recur. But in reality, if they go too far, they're going to start to actually cut through this tract. And the problem is, the way that we've performed this imaging is this weird surrogate measure where we've followed water, and there's lots of kind of thresholds and cut-offs we put into it, which means that I could change one of these arbitrary thresholds and I can make this tract as big or as small as I like. And that means that I can kind of arbitrarily say, well, actually the tract's getting really, really big or small, and so we don't have this absolute kind of idea of what we can actually tell the surgeon of how far he can cut back again. So it's one of the biggest problems that we've got is we create these images, and I don't know if you guys have ever seen any of this tractography stuff, you create them, but it's really, really difficult to faithfully say this is where the edge of the tract is, this is exactly where the surgeon can cut to. Okay, so now looking at the grey matter, so the cortical regions of the eloquent brain. So we use fMRI, that's a technique we can use for mapping out grey matter. So there's lots of different ways of doing it, but because we're a clinical department, we have to take a very basic rudimentary form where we do what we call a boxcar or a block design paradigm. So in this case, if we're trying to identify the part of the cortex that's controlling the hand, we get them to just do a simple finger tapping task. So we get them to tap their fingers like this for 30 seconds. And then we get them to rest for 30 seconds, then we get them to tap for 30 seconds, and we repeat that process about 6 times. And during the whole time, we're taking images. So we're taking, again, entire volumes of the brain, and we're taking an entire volume every 3 seconds. So we go 6 minutes worth of 3-second volumes. And so we get about 10 volumes where the patient's tapping their fingers, and we get 10 volumes where they're at rest. And what we do is you can see that it's part of the fMRI process that when someone's tapping their fingers and the motor cortex is becoming activated, they're actually consuming oxygen, and that means that there's an increase of blood flow, and that means that you actually see a decrease in the signal intensity. But we don't see a decrease in the signal intensity that perfectly matches the stimulus. We see this kind of slightly, so this represents how the signal intensity is changing, say, for a particular voxel as a function of time. We see it, there's a bit of a delay, and it's a bit slopey, and that's because you don't have an instantaneous response from your blood flow. So what we can do from that is we can create images of the parts of the brain that are activating. So here's an example of some tasks that we do clinically. First of all, we look at finger tapping, or if there's a tumour that's close to the part of the brain that controls foot movement, then we might do foot rocking, and finally we do lip pouting or kissy faces, more or less. So when we've done this on a volunteer, and you can see it matches quite well what we'd expect to see from the standard mapping that you get from the cortex. So for our finger tapping paradigm, we end up with activation around about here, and that's in the hand region, fairly medial in the interhemispheric gap, so it matches where we've got activation there. And for lip pouting, it's slightly further down, so it matches where we've got our face area there. So it seems to be quite successful. Our fMRI tasks are activating parts of the brain that we're expecting. Okay, so let's try this on a patient, and we did this one a year or so ago where we looked at the doing a hand task and a lip pouting task because that's close to where the tumour was. And what we found was, you can see there's activation here that does tend to encroach into the region of the tumour. And likewise, the lip pouting activation seems to kind of more or less encroach to the rim of the tumour too. So in this case, there was a chance that the patient may have a surgical deficit because their activation was so close to the tumour, and because this tumour wasn't life-threatening, it was just giving them epilepsy. Effectively, they opted out not to have the surgery because they said they'd rather live with the epilepsy rather than go through the chance of having loss of control of their arms or their hands, or not being able to talk because of lost control of their mouth. Okay, so another functional task that we do is language. So we're trying to look at the parts of the brain that activate when you're talking or listening to language. So there's two areas, Broca's and Wernicke's. Wernicke's is specifically for receptive language, and Broca's is more for expressive language. So you can kind of tailor your task to try and highlight these different areas. So say if you're getting them to listen to something incredibly boring like MRI pulse sequences, then just Wernicke's should activate. But if you're getting them to actually be a bit more expressive through a verb generation task, then you should see Broca's. So in this case, we're showing them a series of words like this, they're nouns, and they have to think of the verb that goes with that word. So if it's chair, they might think sit. If it's tree, they might think chop. If it's hobnob, they might think eat. And they have to think of this. They don't say it out loud because that will cause them to move, but they think of it in their head, and when they do that, that activates the language areas in their brain. Okay, so this gets applied to epilepsy surgery. So around about 33% of epilepsy sufferers are resistant to drugs, and in these cases, often surgery is the best option. So here's an example of someone who's had epilepsy surgery for temporal lobe epilepsy, where effectively the epilepsy focuses in the temporal lobe. And what they do is they chop out a part of the temporal lobe that's around about the size of a tennis ball. And amazingly, patients don't have any massive surgical, massive deficits of this. One deficit they could have is a language deficit, because if their language is lateralized, so it is controlled on this side of the brain, then that means that if they have to chop out the temporal lobe, they could end up having some kind of aphasia, speech deficit. So we run our language fMRIs here because we're trying to work out which side of the brain the language is lateralized on. So clinically, we use three paradigms. There's a picture naming paradigm, the verb generation paradigm, which is the one I showed you before, and the verbal fluency. So the picture naming, we show them a picture, they just have to think in their head of what the actual object is, and that gets them to activate their language. The next one is verb generation. Again, they think of the verb that goes with a particular noun. And finally, verbal fluency is where we show them a letter, and they have to think of as many words as possible that start with that letter. And when they do this, we find that you end up with activation in Broca's and Wernicke's. And you can see here that in this particular case, we got more activation on the left-hand side, and that means that patient actually had left lateralized language. Most people have left lateralized language. About 90% of people have left lateralized language. So what we can do is actually work out what we call a lateralization index, where we count the number of voxels on this side, we minus the number of voxels on the opposite side, and then we divide by the total number of voxels. And this is a measure of just how lateralized the patient is. Okay, so I just showed you a really idealized case before, where effectively it made it seem as though you only ever got activation in those language areas. In reality, whenever you do one of these fMRI tasks, you end up with activation everywhere. You end up with kind of, because you're looking at something, you'll end up with some visual activation, you'll always end up with noise or some motion artifacts. So what we do when we actually calculate these lateralization indices is we apply that. First of all, we normalize our brain, so we take our brain image and we put it into what we call a standard space. We normalize it to a template. And defined on this template, you can actually get atlas regions for Broca's and Wernicke's area, where someone who really knows what they're talking about has drawn regions. And so I can apply this atlas region, and I can mask out only activation within this atlas region, and I can chuck away everything else. And that gives me a more faithful representation of what the true lateralization is, because I'm not including activation, which is spurious and not relevant. So the other problem is, okay, so with fMRI you end up applying a statistical threshold. So I could change my statistical threshold, and I could effectively change what appears to be the amount of activation on the left and the right-hand side. So as I'm moving through these images, I'm effectively changing this threshold, which allows me to only keep really, really strong activation bundles. So what I could do then is do a plot of the lateralisation index as a function of threshold. And you can see in this case, the lateralisation index is always positive, which means we've always got more activation on the left-hand side compared to the right. But as we increase the threshold, it seems like it's getting more and more lateralised. So this is a bit of a problem because these statistical thresholds are a bit arbitrary. So this has kind of become a bit of a conundrum for us, how we deal with this. How do we make a decision on whether someone is really left or right, or maybe a bit of both, when we've got this arbitrary threshold? So still a work in progress a little bit. But what we have done is we've tested this on a volunteer. So we've taken the same volunteer, and this is over the space of about a year. I've tested him on various occasions, and we've just run the same thing over and over again. And ideally, you'd like for the person to be pretty reproducible, but you can see it's completely unreproducible. This particular volunteer, we think, is bilateral, which means that effectively they activate both sides of their brain when they're doing a language task. And so that's the reason why you can see that sometimes they seem like they're right, sometimes they seem like they're left. Remember, above 0 means they're left, and below 0 means they're right. So again, this is a bit of a conundrum. We did someone else who we thought was purely left lateralized, and you can see now they seem to be a bit better, but there's still a lot of variation. You know, this is the same person being tested over and over again. You'd hope that you end up with a consistent answer. And our goal is if we put them together, what we want to be able to do is clinically, can we draw a line through here where we can be sure that if we measure one of these curves that's above the line, we can be sure they're left, and if it's below the line, we know that they're either bilateral or right. And you can see there's a definite difference there, but there's some amount of discrepancy. Okay, so we've not only tried this on volunteers, we've tried it on patients as well. So here we've got one patient who had a left-sided lesion, so I think this is the lesion down here that happened to be close to their Wernicke's area. They had surgery and actually found that they had a post-surgical language deficit. So this is an ultimate validation that their language was definitely on the same side as their lesion, which is on the left-hand side. So if we look at their functional activation curves, we see that they are consistently, so I've done two different tasks here. So the solid lines is the verbal fluency task, and the dashed lines is the verb generation task. And the colours represent a different region. Green means both Broca's and Wernicke's combined, and red is Broca's and blue is Wernicke's. So what you can see is that it's always positive, and that means that it's always left lateralized. And so it's not good for the patient, but this is good in that it seems like our fMRI studies are working. Our fMRI said they're left lateralized. They had a deficit after surgery, which means they definitely were left lateralized. So it's kind of a good validation. Okay, so now we've got another patient. So this patient had, do you remember in that little movie I showed you before where they were using electrodes to zap the brain and they would see the patient move their hand? So they actually did this during this surgery. So again, that's an ultimate validation that we're sure that they're left lateralized. So they were zapping the part of their brain that wasn't moving their hand that was controlling their language, and they got the patient to do some language tasks or try and speak whilst they were doing it, and they found that as they put the electrode onto the language part of their brain, they were unable to talk or unable to listen properly. So again, we have this ultimate validation. But what we found is that from the fMRI study that we did before their surgery, there was a bit of an ambiguous answer in that there were certain cases, we've repeated the same task over and over again, there's certain cases where it says that they're actually right lateralized. So this goes against what we found from this intracortical stimulation. So this was a bit of a quandary, so we've done a bit more work. Yep, so that one was a question. Done a bit more work, and this is back to the same slide as I had before, where I was saying that effectively our lateralization index is calculated through counting the number of voxels in each region. So there's a an extra statistical type of analysis you can do, which is called a bootstrap analysis. And what we do here is that rather than counting all of the voxels in these regions, we just randomly select, say, 1,000 voxels. We take 1,000 voxels from this side and we take 1,000 voxels from this side. And then we sum together all of the activated voxels and we work out a lateralisation index for those 1,000 randomly selected voxels. Okay, and then we do this again, and we do it about 10,000, 20,000 times, and that allows us to build up some statistics of how sure we are of our lateralisation index. So these are represented by these little kind of sharp spikes we've got here, which are actually histograms, which are representing the number of times we've measured a particular lateralisation index in when I've repeated this, say, 10,000 times. So the upshot is that the sharper this point is, the more faith we have in the lateralisation. The broader the curve is, the less faith we have, the more spread the statistics are. So in this case, you can see, and the other thing is we've got a number of these actual curves here, these spikes, because we've done it for a number of thresholds as well. So what we find is that at the higher thresholds, we end up with very, very defined lateralisation. At low thresholds, where we've got lots of spurious activation, we end up with a fairly broad distribution, which means that we're fairly uncertain exactly what the lateralisation is. So what I've done is I've taken this bootstrap analysis and I've applied it to that patient that was certainly uncertain before. And we had this curve down the bottom here. And what I found was that these bootstrap statistics suggested that it was really uncertain exactly how sure we were of the lateralisation. And if we compare it to this other curve up the top here, you can see, particularly for the higher thresholds, there's a lot more certainty. So in a way we can say, well, maybe this one was just a bit of a spurious result, that effectively this curve down here was just a poor fMRI study. The patient may have been moving quite a lot or just not performing the task properly, which again gives us a bit more faith that we should be believing these ones, and these are the ones that we are sure were right because they tested that they were left lateralised during the surgery by this electrical stimulation. Okay, moving on, so to a bit of clinical research. So particularly we do a bit of deep brain stimulation over at the Royal Hospital. So deep brain stimulation is where we actually stick a wire into the middle of the brain and we fire a current through it, and that abates certain symptoms of certain diseases. So typical things where this can be used for is essential tremor or Parkinson's disease, a disease called dystonia, which is a bit like Parkinson's but mainly in children. They use it for depression, for chronic pain, for Tourette's. And recently, about 5 or so years ago, they took a patient who was in a minimally conscious state. They had a traumatic brain injury, and so effectively was nearly vegetative. And then they applied deep brain stimulation, and they found that actually it woke the patient up, more or less. They were able, at the end of it, that they were hardly perfect, but they were able to say some really rudimentary things or understand things, and they even got to the point where they're able to feed themselves. So it's kind of a fairly cutting-edge treatment, which is being applied to lots of different areas at the moment. So the things that it's used in routinely, and the things that we use across the road is these three, and it's been used for a good 10 or 20 years. There's lots of research studies, and we're involved in one for depression across the road, and the other ones are being done at other places. Okay, so I've been particularly involved in a project to do with dystonia. So again, this is a syndrome where a patient has like sustained muscle contractions and repetitive movements. So it's a bit like Parkinson's disease. You see them as having like the same movement disorder as Parkinson's disease. So there's two types. There's primary dystonia, which effectively has some genetic origin, and then there's secondary dystonia where the patient might have had brain damage, and typically it's at a really young age. They may have had some hypoxic event, like the umbilical cord caught around their neck or something like that, and that's caused damage to their vital part of their motor network in their brain. No one really knows exactly what the causes are of it. All they know is that if you effectively target these deep grey matter structures, like the thalamus and the globus pallidus, through deep brain stimulation, then it actually helps to abate the symptoms. So there's kind of like the actual cause of it isn't really known very well. And so here's an example of what deep brain stimulation is. We effectively stick electrodes in and then you have a pack here. It's a bit like a pacemaker that fires current through the electrodes, and they're continuously firing, and when they do so, it helps to abate the symptoms. And here's an X-ray of a patient that's actually got these electrodes in. Okay, so here's a movie that I grabbed off of YouTube. So this is someone who's gone to the clinic with dystonia. So in the beginning, they've got their DBS electrodes on. And after about 30 seconds, you'll see they turn them off and the symptoms kick in. So you can see how effective this actually is. So they're getting them to do just standard kind of like movement type of tasks to get an idea of exactly how bad their dystonia is. Remember, this is with the electrode on. Okay, now they've turned it off. You can see instantly there's an effect. So yeah, you can see it's quite an effective treatment, and I mean it's quite invasive because obviously the patient needs to live with an electrode in their brain for the rest of their life, but it has quite positive outcomes. So how do we actually perform these DBS implants? So this is where I get involved as a physicist again in the imaging department. What we can do is we can set up the patient so they're imaged with a head frame on, so it looks like that thing on the left effectively. And they screw bolts into their skull so that effectively it holds the frame into position. And within the frame, within its kind of structure around the outside here, is there's MR opaque little markers. So when we take an image, an MRI image, you end up with like these little dots here. So what this does, it gives you a reference between the structures inside the brain and the structures outside. So it allows us to kind of accurately target exactly where we want these electrodes to go. So a patient that's coming in for surgery, we attach them to the head frame, they have this preoperative MRI, and then a surgeon will identify where they want the target to go. Which will be that red dot there in this area called the globus pallidus. Okay, so they then attach this kind of attachment to the head frame, and because we've got this reference between where we want the target to go and these dots on the outside, they can angle exactly where they put, or where they insert the lead and exactly how far they push it through, and the idea is they should be able to get it to exactly the point they're expecting it to go to. Doesn't work perfectly, because as soon as you sort of drill a hole in the brain, or even if you have the patient laying in a slightly different position, the brain will shift a little bit. If you drill a hole through the skull, you'll release a little bit of pressure and the brain will move. So what we do is we do some imaging afterwards, where we take a CT, and then we fuse the CT with the MR that we took beforehand, and we can see how well the electrode shows up from the CT image. We can see how well that is aligned with our target point that we had from our initial MR. So we can't, ideally we'd like to do an MR after the surgery as well, but there's heating issues with having a big long electrode, so we have to do a CT afterwards and do this fusing technique. Okay, so some research that I've been working on, there's a paediatric neurologist who's gone back to do his PhD, and he works as a doctor in this movement disorder clinic, working with kids that have got dystonia. And so he's trying to investigate where is the optimal target location to put these electrodes. I mean, effectively, the reason why they know that you target this globus pallidus, particular part of the anatomy, it's because it's purely anecdotal. There's no real kind of theory underlying what's going on. We don't know what the causes are. Effectively, what's happened over the last, say, 100 years, or ever since we've had imaging, they've identified that certain patients have lesions in this area, and certain patients will have had dystonia as well, and they've found that by having a lesion in this area where effectively it kills off some of the tissue or disrupts some of that tissue, it's abated the symptoms. So at some point they thought, well, maybe we should burn this area deliberately to try and abate the symptoms, and then they thought, well, why burn it? Why not just try and stick an electrical current through there, and then it can be reversible if we want it to be. We can turn it off if need be. And so it's all anecdotal. This is the area you should go to. So what we're trying to do in the research here is we've taken all of the patients that have been scanned over the last so many years at King's. We've registered their brains into a standard template again. And we've looked at where this distribution of the electrodes are for all of these patients in the standard space. And then what we've done here is we've color-coded, so these are all of the different electrodes for some of the patients we've looked at, and we've color-coded it according to outcome. So there's a scale of outcome where effectively you get the patient, you see how much movement they've got and how much strength they've got. And effectively, the more yellow something is, it means the better their outcome has been from the surgery. And so, effectively, through this, we can actually produce evidence which says this is going to be the best target where the cluster of best outcomes are. So we've done it for primary dystonia, which is this genetic dystonia, and then for secondary dystonia, you can see there's a marked difference. So that secondary dystonias have far poorer outcome. There's a much bigger dispersion in exactly where you are targeting the electrodes. And so the other thing that we've done is we've actually run probabilistic tractography. So because it's a movement disorder, we're certain it's a problem with the movement network within the brain. So the movement network goes from deep brain matter structures like the subthalamic nucleus, thalamus, globus pallidus, up to the cortex and creates a bit of a loop. So by targeting the globus pallidus, you're targeting somewhere in the motor network. But the globus pallidus kind of has white matter connections to lots of other areas as well. So what we've done is we've said, well, let's run some probabilistic tractography, and let's run it using the globus pallidus as our seed region, use the precentral gyrus as our target region, precentral gyrus being the motor area in the cortex, and let's see what area of the globus pallidus has the strongest connections to that motor cortex area. And what we found was that it's this area in the internal globus pallidus down here, which actually does correspond quite well to where this anecdotal evidence says that you should be targeting, or where surgeons are actually targeting their electrodes. So our idea is that one day maybe you could use this probabilistic tractography to individualize your targets, where effectively rather than just taking a stab at somewhere in the internal globus pallidus, you could say for every patient, run this probabilistic tractography and target the electrode into the peak of the connectivity as part of this motor network. So that's kind of the final goal of where we're trying to aim this type of work. Okay, and that's it.
Thank you very much. I know that most of you have to leave around 2, so just if you want to ask quick questions, fire away. Otherwise, feel free to leave and the rest can stay for questions. Okay, Anushka?
dystonia. So, in reality, the retrospective data we're looking at, we've only got, say, 20 or 30 patients to look back at. It's a prospective study. It's like stuff that I was showing you, the probabilistic map was actually not on children's data. We don't have good enough diffusion data for that. It's an example on an adult volunteer. But the idea is that we've now got ethics to run sort of 64 direction tractography data in all of the kids from now on, so that we can effectively build it up.
Is there evidence that using the DBS over a long period of time, it becomes less effective, or does it stay?
So yes, I think so. I can't give you much more.
No, but I mean, how long has it been going on for? So how long do they know that it does work?
So in dystonia, so it was FDA approved in like 2002. So really, there's not been very many cases from before that. And for Parkinson's, it's kind of mid-90s, or essential tremor, I think, was the mid-90s. So you really don't have much more than a decade or two of data. So
So it sounds like the Oliver Sacks awakening sort of will go away after a while.
Yeah.
Yeah.
And so it's a question of if it stops working because effectively the effect stops working, or whether the electrodes just start to move a little bit over time. I mean, if you scan patients after a while, you see the electrodes are moving. And so there's been times where there has been a fairly big disruption in the ability for it to work well. They've found the electrodes moved, and they've actually gone back for more surgery, and they've replaced the electrodes. So, yeah.
You said before that you do a CT after the surgery and an MRI before.
Yeah.
How well is the match between those two?
So I can really give you a number in my head. 1.8 millimeters.
Okay.
Yeah, it's really good. It's it's nearly as good as what the resolution of an MR is. So you don't lose anything by doing the CT afterwards and doing registration.
So it's reliable enough.
Yes.
To
Yeah.
actually take it.
Yeah. I mean,
That's okay. On the back of that, I believe the original kind of tracer work comes from CT imaging, and you were showing, I believe, I don't know if it was diffusion, to show sort of the outlines or the volumes of tumors in MRI. Is that correct?
So I used perfusion.
Yeah, I think that's the one.
Yep.
So basically, my question is: do you think that in the long run, MRI is going to overtake CT in order to find the outlines of those tumors?
Yes.
Yeah.
Yeah.
Okay.
I mean, I think it's kind of recognised as it's a much more faithful modality, and you've got much more of a kind of elaborate soup of things to throw in there. I mean, perfusion doesn't work sometimes, and so you put in maybe some spectroscopy, some spectroscopic imaging. So
exactly.
Yeah.
Interesting. Thank you.
I mean, you can, with those outlines I was drawing, you can add outlines for tracts as well from DTI, and you can add outlines from functional activation from fMRI too. So yeah.
That's the bit that you were showing to have it in the microscope.
Yes.
Ah, great stuff.
And what I didn't say was, so microscope is one way. Another way is they have like a TV screen.
Yeah, exactly. Yeah, I've seen that.
And they have a special wand that is effectively a magic wand. It's like registered. So through the idea of having like these markers when they're doing the imaging.
So it's an additional marker, basically.
Yeah. So they can point to somewhere in the brain, and they can look on these images, and they'll see a dot appear on the MR images, and they'll know, okay, that corresponds to that region there, and so they can see that the point they're pointing to is the edge of the tumour, and they know that that's all they need to cut to.
And then going with the sucker and stuff. Yeah.
Yes. Yep.
Why did you use a contrast agent for perfusion rather than something like ACell?
Because it's quicker, massively quicker, and we're injecting contrast anyway. And it gives you more signal to noise, which is why it's quicker. You don't have to worry about doing it ASL. You do it over and over and over again to get a decent signal. But with the perfusion, you just do it once. It takes about a minute, and you get the images.
In the case of Parkinson's disease, so it's a progressive neurodegenerative disease. So when you have the electrode, I mean, coming back to your question, maybe it also, the effect wears off because the progression is still happening. So it does delay it.
Yep. Yes, good point. So I mean, I kind of primarily involved in dystonia, where a lot
Yeah.
of the time it's some insult that's happened at birth that's
exactly.
caused it. But yeah.
Is that a method that could be applied to like Alzheimer's disease, for example, or has it been tried at all?
So I've not heard of it for Alzheimer's disease, but so I'm not sure. It wouldn't. I mean, everyone's thought about trying it with everything.
Yeah,
it
just
seems,
anything that touches the brain.
Yeah, exactly. I mean, with say Parkinson's disease, if you end up with some progression of the disease, you can always go back and you could change, say, the amplitude of the stimulation or the frequency of the stimulation, so you can kind of tailor it in situ to hopefully, match the progression of the disease as well.
Any other questions? Nope. Okay, I think that's it.
Cool.
The next talk is going to be the 3rd week of October. Do you know a date?
We haven't got a date. I'm not sure of the date.
It's a
Okay,
Thursday.
bye now.